Hello, everyone. So we want to get started as much on time as we can. We have a lot of amazing content to deliver to you tonight. Second talk in our event series, Bio 5 Precision Wellness in the Time of COVID-19. My name is Lisa Romero, and I'm the Senior Director of Public Affairs, Communications, and Engagement for the Bio 5 Institute. Thank you all for joining us this evening. Bio 5 connects and mobilizes top researchers to find creative solutions to humanity's most pressing health and environmental challenges. Since 2001, this interdisciplinary approach has been an international model of how to conduct collaborative research and has resulted in disease prevention strategies, promising new therapies, innovative diagnostics and devices, and improved food crops, and includes the precision nutrition and wellness as initiatives as one of our focus areas. First, I'd like to introduce Dr. Ski Chilton. Dr. Chilton is the director of the Precision Nutrition and Wellness Initiative and a Bio 5 Associate Director, who will also be the moderator of the question and answer session at the conclusion of Dr. LaFleur's talk. Dr. Chilton.
Thank you so much, Lisa. I just want to once again remind everyone, this is a series that's part of the Bio 5 Institute for Precision and Wellness, Nutrition and Wellness Initiative. The mission of this initiative is to optimize the state of health of individuals in order to predict and prevent disease and increase overall quality of life. It's achieved through integration of next generation technologies, through scientific research and personalized nutrition and lifestyle design. Here we value education, and in particular education that promotes health. So in this series, we've really chosen speakers who are at the top of their games. And tonight is no exception. So we really look forward to this seminar tonight that will be relatable to all of us.
Great, thank you, Dr. Chilton, and we're going to hear some more from you later on as well. Tonight's lecture will be presented by Dr. Bonnie LaFleur, a research professor of biostatistics in the Bio 5 Institute, with a joint appointment in the Melanie Zuckerman College of Public Health. Dr. LaFleur has dedicated more than 30 years to her work as a collaborative biostatistician and a scientific leader in precision medicine. Tonight, she'll share information on a much anticipated eventual transition to normalcy amid continued COVID-19 testing and vaccination efforts. So audience members, please, you're welcome to type your questions in throughout the talk in the Q&A box located at the bottom of your toolbar on your screens. And we'll be sure to leave time at the end of the talk for questions. And we're gonna try to limit it during the talk so we can keep Dr. LaFleur on track. And then we will save as much time as possible and get to as many of you at the end. So with that, Dr. LaFleur, we're delighted to have you with us this evening.
Thank you very much for the introduction. Ooh. So as I was introduced, I'm Bonnie LaFleur, and I am a biostatistician in the Bio 5 Institute. And during the pandemic, I've been working along with our local and state public health officials in tracking and monitoring and predicting cases across the state, COVID-19 cases. And also I've been working a lot with my public health colleagues trying to devise mitigation strategies for people to keep us all safe. So early, when I first came up with the title of my talk, as you all know, I said, okay, what's normalcy going to look like? We're going to turn to normalcy. Well, since then, and after some internal reflection and also discussion with my colleagues, I realized that actually the title of the talk is more what are we going to do as we turn towards something new? Because normal is now redefined for all of us. So the goals of this talk are to kind of provide a foundation of where we are right now in terms of the pandemic and with respect to COVID-19 mitigations, as well as identify personal and social behaviors that might lessen our short and long-term risks, and provide strategies, maybe even more importantly, to provide strategies to navigate social interactions now and also in a post-pandemic world. A document with a set of hyperlinks that can be used as references and resources for a lot of the material that I'm presenting tonight will be provided on the Precision Wellness website, as well as uploaded to the chat box during this talk. So when we talk about COVID-19 mitigation, one of our primary mitigation techniques is COVID-19 testing. So I'm going to give you kind of a background of where we might go get tested. Some of you might already know some of these, and I'm going to try to start peppering in how this might be changing as we wander through this vaccinated world. So there are 3 types of COVID-19 tests. 2 of them actually are diagnostic tests that measure active infection. Those are antigen tests and PCR tests. Antigen tests are typically the specimen collection is either a self-administered or an administered nasal swab, and you can usually get your results in about an hour or even under. PCR testing is also used to diagnose active infection. The collection method is either nasal swab or possibly even nasal pharyngeal swabs, which go a little bit deeper up into the nasal cavity, and saliva. And here at the University of Arizona, our students have also been able to use a novel sample collection that uses a gargle, a rinse in your mouth. It's pretty cool. These results, as I said, are usually 24 to 72 hour turnaround time, depending on the lab that that's actually evaluating them and how busy they are. The third type of test is an antibody test. And this is used to actually evaluate whether or not you've had a prior infection, and it measures your response to the virus. The results from this test are usually returned back to you in 7 to 10 working days, and it's a serology test, so that it requires a blood draw. Now, for both the antigen tests and the PCR tests, we usually would evaluate you and say, are you positive or negative? And if you were positive, then you would be open to contact tracing so that people who might have been exposed to you might know it, and you might know who the people are that you were exposed to. And the reason that we wanted to do this is we want to limit the continued spread of the virus and reduce that infectivity. So we would ask you to isolate and self-quarantine. If you were negative for the diagnostic tests, we would say you're an at-risk person, meaning you haven't yet had the disease and therefore you're still susceptible for the disease. Well, now actually, now that people are being vaccinated, we can reframe that conversation. And so if you've had a negative test and yet you have been vaccinated or are fully vaccinated, then basically you are at low risk. And so we'll talk a little bit later about what this means, but I did want to reframe the test results in the context of now that we have people who are vaccinated and are still being tested. So with respect to the diagnostic viral tests, we would like you to continue to get tested if you have symptoms, regardless of your vaccination status. We also would recommend that you get tested if you're in between your first shot and 2 weeks post your second shot, or 1 week or 2 weeks after your 1-dose J&J shot, and have had a known exposure. So anytime you have symptoms, you should continue to get tested. And even if you don't have any symptoms and yet you have a known exposure, if you're in between that time of vaccination or between your 2 shots, we would prefer that you get tested if you've had an exposure. There's no need to be tested or quarantined if you are 2 weeks beyond your second shot or your 1-dose J&J shot and have had a known exposure. So this is great news. And also, we just want to let you know that no, you will not test positive for a COVID-19 test, for a viral test, if you've been vaccinated. So you will only test positive if you currently have virus in your system. PIMA County has free testing sites throughout the county, and their testing sites are located on their website. This link is actually included on the resources page that is being shared with you. I highly suggest that you look it up if you want to be tested or need to be tested. These sites do change. There are some larger sites that have been open since the beginning of the pandemic and likely will be open for a very long time. But there are also smaller pop-up sites, and those come and go depending on where we're seeing a large amount of cases and also just a need by the community. So check the centers near you if you need to be tested, but these are free. Also, all residents of the state of Arizona are eligible to receive free antibody testing through the State of Arizona University Arizona COVID-19 Antibody Testing Initiative. And if you look up on this website, the COVID-19 antibody testing.arizona.edu, you can hit on a link and sign up to get your antibody test for free. So that's the mitigation with respect to testing. Now we're going to move on to some other types of mitigations. And this is really the start of the talk about how we're going to interact now in the short term. And when I say short term, I'm talking 4 or 5 months, and then possibly even beyond that. So exciting news, vaccinations are here. And every day we see more and more people that are being vaccinated. Here in the state of Arizona, as of I think 4 o'clock this afternoon, we have 22% of the Arizona population has received at least 1 dose of any vaccine, and 13% of our residents have been fully vaccinated. This is about the same nationally. I believe the rates nationally as of about 4 p.m. or 19% of the US population has received at least 1 dose of the vaccine, and about 10% have been fully vaccinated. So this is really good news. And every day, this little plot is created that says, if we're vaccinating people at the same rate as we are right now, when do we think that we're going to have about 90% of our population fully vaccinated? And it was great. Last week, it was sometime in September. And over the course of about 9 days, we now are seeing around August 7th is our target date for approximately 90% of our nationwide citizens being vaccinated. These are our successes. Vaccinations lower our risk of severe COVID-19 illness. There's a real synergy between individual protection and limiting transmission by lowering susceptibility of infection, meaning the more people get vaccinated, then the higher our individual protection, and vice versa. We need to lower the chance of viral reproduction through infection, because this also will protect us against any variants that are floating around. So the more people that are vaccinated, the less impact those variants are going to have. Vaccinating our communities help us return to some level of pre-pandemic socialization. It is important to note that as we ramp up all of our social activities, though, we need to continue to protect ourselves and also protect other people so that the vaccines can do their job. So what do we do in the next 4 months and perhaps beyond? It's really important that we be able to socialize. Depression is really at an all-time high, and pandemic fatigue is a real thing. However, it's not like the pandemic is going to end like a turning on or off of a light switch. We're going to have to learn how to interact socially, not just over the next 4 months, but also probably going beyond that. However, the good news is there are ways of maintaining good public health practices and minimizing risks while we socialize. So early on in the pandemic, some of you may have heard the term social pods or quarantine pods. You probably heard them through our professional and collegiate athletics. They were one of the first to put into context the idea that people need to be able to do a sport safely. And one way to do this is to limit their external activities so that they can continue doing the one thing they wanted to do, which was play contact sports. Many other people started to think about these quarantine pods or social pods probably around last May or June, because people were already tired of lockdown and isolating. And I'm actually trying to reframe this word because we're kind of moving into a new period of the pandemic. Like I said, we're kind of slowly transitioning. We're turning a corner, as it were. And so I'm trying to come up with a new terminology, and I asked a few students and I asked a few friends, and the two terms that everybody seemed to like were either COVID or social cores. I kind of like the idea of circles as well, but basically what these are a group of friends or family that decides to socialize together. They agree beforehand to limit their in-person social activities outside of the core as much as possible. And the way that they establish how this is going to happen is through this idea of a social contract. And I know contract sounds kind of, legal. It isn't, but in a way, it is a contract. And so I actually do still like the term. They're difficult to navigate because what it means is you have to have upfront conversations with people so that everybody agrees ahead of time on what the quote rules of engagement unquote are going to be. I will say that a lot of my friends who have actually participated in these types of pods or cores, if you will, actually write down their social contracts, not because it needs to be something that is a static document, but more, it is a living document that everybody needs to be able to agree on, update frequently, and actually have tangible contributions to. So just keep that in the back of your mind as I talk through some of these things, that I personally like the idea of writing it down, but not everybody feels that they would need to do that. And again, I'm going to highlight this, that we're going to do this in the context of following recommended public health practices. So there's a history behind, before I even get into anything, I like to give people a background. Relearning socialization techniques. So there are about 12 years between the time that the AIDS virus was actually identified and medications for HIV infection were available. Now, HIV is practically it's an illness. It's not a death sentence. But during this 12-year period, people really had to limit their behavior in order to stay safe and not spread the disease. And the disease was almost always fatal. So these behavioral and social changes included very tough, but very necessary open dialogue about risk factors that individuals have and risk tolerance that the people they interact with have. And while COVID-19 doesn't quite have the same stigma as these people had while they were entering their social contracts, we still need to have the same types of conversations. For example, I'm comfortable eating dinner with others that have been vaccinated. Are you? And by the way, that's not me. I have a little different risk tolerance, but that's okay. Those are the kinds of conversations that we have to be able to have now with our friends. There's also a science behind this. There's a really cool paper that came out late last year, where some sociologists actually they did a study on network analysis. So panels A and C are networks of people. Each of these circles are a person, and believe it or not, both panels A and C have the same number of people in them and the same number of connections, which are lines that go, these light gray lines that go between each individual. Now, this square in the middle of both panels actually is an infected person. And this sort of boldish line is the path by which this single infection goes through the social network. And what you'll see is that the path between panel A is shorter. So it actually has a shorter path before everyone in the network is infected compared to panel C. The other thing that you'll note about these two panels is that the colors, the red colors versus the blue colors, are the similarity or the closeness in proximity between this infected individual and each subsequent person who was infected and then spread it through their social network. And so you can see panel A, all the people are very closely connected to this single point of infection versus panel C, where people are actually quite spread from that single point of contact, except for a few people right at the very beginning of the social network. So what these panels show, though, which is really interesting, is that if you have a type of infectivity that's shown in panel A, the resulting basically infectivity curve is like a peak And remember, early on in the pandemic, everyone was talking about what we needed to do was flatten the curve. Well, what happens is if you can actually reduce that initial point of contact from closer proximity infections to farther away infections, it actually results in that flattening of curves. So what these authors suggest is what we need to do is try to figure out a way that we socialize so that we have more of panel C and less of panel A. So the way that they suggest doing that is actually going through different types of contact reduction strategies. And panel A shows a contact reduction strategy where each of these colors that are similar colors are kind of like our microenvironments or our pods or our social cores. And in panel A, even though we have these social cores, we also have a path from one core to another. What's interesting about this paper that I have to say as an aside is one of the examples that they use are geographic separations. For example, small villages that are far away from each other, and they look kind of like panel B. You've got these geographic villages that are scattered around a countryside. And if you don't have a lot of long interaction between the two villages, you end up looking more like B than you do C. So that's a geographic type of microenvironment. And we might, on the real extreme side of this, would be Australia and New Zealand, right? Because they were able to self-contain themselves. They had very little bridging between them and other geographic continents. We also see this in Alaska. I was listening to NPR a couple of weeks ago and they told this fascinating story about this very small village in Alaska that has basically had 0 COVID-19 cases through the entire pandemic. Part of the reason is because they're geographically remote, but the other reason is because they suffered greatly during the Spanish flu epidemic. And because of this, as soon as the SARS-CoV-2 epidemic or pandemic started, they reduced contact with other villages. And they did this in such a way that they have actually had no COVID cases. It's just a very fascinating story. So anyway, what we'd like to do is try to stay like A and B, but even more, we'd like maybe to be more like panel C, where we don't have any bridging or as little bridging as possible. And what happens to get you from just this geographic or similarity? So I've been talking geographic. Let me go back 1 minute and say, what about if we maintained our social cores to those people who are just similar to us, maybe not geographically, but similar, we have something in common. So maybe we're runners and we would like to limit our social interactions to running related activities. We can do that, and it's actually a fairly safe thing to do as long as we limit our external contacts as much as possible. And the way that we do that is our social groups actually have a lot of friends in common. So any social interactions that we have outside of our social cores are likely going to be with people who have common friends, for example. And that's what this panel C is talking about. That's one strategy, is if your primary exposure is work, then maybe you can socialize with people who you already share this maybe risk profile with because of your work, you carry that into your socialization as well. So that's another example. Panel D, which is the ultimate kind of a core strategy, is one where you have frequent contact with exactly the same people and have very, very little contact outside of this frequent and constant contact. So it's very hard to get to that kind of a core, but if you do, one of the things that you can see is that it basically disconnects you. It reduces any of the outside kinds of contact that occurs in any of these other activities, and it basically puts you in a very low risk or disconnected state. So this is like science. It's a very cool way to show things that we've been hearing about for the past year. Now, let's talk about what we're going to do now, though. We need some social definitions before we can think about gathering together in our social cores. One of the things we have to think about are risk factors. Now, these are risks that people bring into the core or the group. And this could be medical, or it could be exposure. So if I'm an essential worker and I have to go to work every day and mingle with other people, that's a risk factor that everyone has to consider when they socialize with me. If I'm a person with a comorbid, some sort of a disease that would, if I were to be infected, would put me at a higher risk for a bad outcome, then that's a risk factor that I'm bringing into the core. There's also this idea of risk tolerance, and this is, I may have a different tolerance than another person of my same age and of my same risk factor. And that's okay. I don't know how many of you actually heard the interview that I gave through the science talk that actually introduced this particular talk. But one of the people who interviewed me asked me if they were going to have to shake hands with people once we're all seeing each other socially again. And that's one of those questions that, no, you aren't. You're going to have to be able to, when you see your friends again, you're going to have to be able to discuss with them what your risk tolerance is about hugging, about shaking hands, about fist bumping. And then there's this idea of the social contract that I alluded to, where there's agreed upon behaviors, both when socializing and also during your daily life when you're not socializing, that everyone has to agree to. And then here's the most complicated part of all, because remember, I told you these quarantine pods or social pods, this idea has been going on for a year now. We're evolving to a post-pandemic life, and this is happening very rapidly. So while we're discussing all of these risk factors, risk tolerance, and social contracts, we have to do it in the context of updated public health guidance about the spread in the community. What's our community health looking like right now? How, are we in the middle of a high risk spread or not? And also the guidance that the CDC and other public health officials are giving us about our best public health practices. And these might be expansive, meaning we're able to do more things, or they could be contractive, meaning we might need to think about doing fewer of those things. All of these elements are going to change over time, and they may influence how our social cores interact. So the risk factors, as I said, are like age or health status of individuals or their families, the type of work that the pod or core members may do, essential workers, healthcare workers, for example, and how many other social networks do people interact with? Like how many people have been going to grocery shopping or doctor's visits? And as you know, this is all changing every day. So now it's almost everyone's doing most of these things at some level. So how do we talk about this? Well, for example, just a quick example, suppose we had 3 different households. One household, we have one person works from home and the other works in a library that's open to the public. There's no other exposures. Household 2, both partners work from home and their child attends school virtually. No other exposure, but one parent has type 2 diabetes. And then we have household 3, a person who works at home, doesn't have a car though, and has to take public transportation. She also gets her hair cut at the salon. So everybody has to agree, what's the risk that you're willing to take to have all 3 of these people interact socially? So one thing that we need to do is be able to have a conversation about these risk factors, which are the whether or not you're working from home you do, or what kind of risk, illness risk factors you may have, and then what your risk tolerance is, and find a comfortable ground. We also need to always evaluate this in terms of our external factors, which is like community transmission and vaccination levels. But for example, for this particular example, it's this person says, I really want to see you guys in person, but to the person who's taking public transportation, I feel uncomfortable with that. So if we're going to get together face to face, can you lower your risk by maybe not getting a haircut? And could I give you a ride to the grocery store instead of you taking the bus so that we can get together? And the other person says, yes, I can do that. We're entering into a social contract. We have to actually be able to do this honestly, and we have to be we have to trust the people that we're interacting with. So people may have to leave your social core because they are not comfortable with the current practices of the core, or because maybe their risk factors have changed. So what if their parents came to live with them and now they actually they don't feel as comfortably socially engaging with people anymore? Also, the core may feel less comfortable about other people's external social contacts over time. And you need to be able to do this without judgment. So we have to all remain friends. I mean, this is how it worked in the HIV/AIDS era. And this is how it's going to work as we go forward in the post-COVID-19 era. Shaming is not an option. It never changes people's behavior. Honesty is really the critical part, and we all need to be able to trust the people that we're interacting with. We're going to have to discuss the inside core rules, like what are we going to do together? How often are we going to meet? Where are we going to meet? What are the expectations of our particular social core for external types of activities? Some social cores might have enough people that are at risk that maybe they don't want to have other people who they're meeting with socially, at least face to face, who have a lot of external activities. So if they belong to a lot of other social cores, then maybe they can't belong to mine. We also need to have a way that we're going to review these frequently. And by the way, reviewing them now is positive because we are always updating all of the cool things that we're able to safely do. Okay, so it's not just a contraction that we're talking about when we reevaluate our expectations, but it might be an expansion. One of my favorite resources is a checklist by a guy named Joseph Onmanson with guidance from the COVID-19 working group in New York City. He has a checklist and he talks a lot about individual risks and how those risks actually become risks for the whole group and really need to be negotiated ahead of time. He highlights a lot of social public health mitigations that need to still be adhered to. And the way he frames it is, the more of these things that you do that might be risky, the more your risk is. The fewer you do, the lower your risk is. We also need to discuss our outside core rules. So, are social interactions outside of our core permitted? Are they only outdoors, only with permission? What about partners and roommates? Do they have to actually look at our social contract or not? So these are all things that you have to be able to discuss openly with your core. And it really is important for people to understand that a lot of people's risk factors are not of their own doing. Some people have higher risk jobs. So how are you going to communicate these potential exposures with people in your social core? And what can we do in our social core to support the people who belong with us, even if it's not face-to-face? Like, how can we continue to interact with people, continue to support them, even though their risk might be different from ours? So again, we're going to have to deal with conflict about risk. We're going to have to learn to deal with how you engage if someone's not following the agreed upon guidelines. Usually this isn't severing contact with people, it's just having a frank discussion and still hopefully remaining friends. Again, how are we going to change our social contract over time? And can people be added to the group? Like, as more and more people are vaccinated and as our community is is continuing to lower their risk, how do we actually include more people into our social core? Now, I know I'm just going to ask this question out here because I know you might be thinking it. What is a safe core size? And actually, there's no real guidance on this. There's a lot of what you can do if you're vaccinated. There's a lot of what you can do as long as you continue to socially distance and wear masks. You can congregate in larger groups as long as community transmission is low. And obviously, and as more and more people get vaccinated. However, I wanted to throw out what happened last week was the United Kingdom moved to their roadmap for reopening, and they're going for a rule of 6, which means that you can safely socialize closely with 6 people, although they still are maintaining that mask wearing and social distancing take place even with the rule of 6. And these are all for outdoor activities. So I think it really depends on who you talk to, what a safe core size is, and also it really matters what kind of external influences there are that are going on, like what's community transmission like and what's the vaccination rate right now. One of the things that we talked about early on in terms of our social pods and quarantine pods are agreeing ahead of time on a testing plan. Since we still are still not all vaccinated, it's probably a good discussion to continue having, at least for a while. And this is how often are people in your core or pod going to get tested? What's going to happen after an exposure? How and where will people get tested? Does anyone in your social core or even outside of your social core need financial or emotional support for testing? If you have a positive antibody test, vaccine, or have had previous COVID infection, how's that going to change your pod rules? So these are the open, frank discussions that we need to be able to have as we engage with people socially now and in the near future. We do have some lower risk group activities that we all can do. We live in a beautiful place pretty much year round. Outdoor barbecues and picnics with social distancing and masks when not eating, one person handling food are very low risk activities. Hiking, walking, running, outdoor yoga, all very low risk activities. We still would like people to avoid being indoors if possible. Obviously, this changed with the CDC guidelines for vaccinated individuals, but for a mixed group of both vaccinated and non-vaccinated, and just as general safety, when indoors, open windows, wear masks, try to socially distance, and always carry plenty of hand sanitizer. We can't say this enough, right? We need to be flexible in our size of our core groups of people, and we need to be able to expand and contract based both on group preference and taking community transmission and public health recommendations into account. Sometimes we'll expand, sometimes we're going to contract. We have to actually have this flexibility built into our social cores. So, an example, mitigating risks in 2021. Some of the questions we might need to ask now, now that we're in a vaccine world. Is everyone in your social core vaccinated? Once your social core is vaccinated, are you going to actually change or update your inside or outside of the core activity expectations? So are people going to be able to be more social outside of your core? Will vaccinated people in your social core still wear masks? This might still be something that you have to do given risk factors of the people that you're socially interacting with and their families and what they do outside of your social core. So will vaccinations of people in your social core change with updated CDC guidance around isolation, travel, interactions among other vaccinated people? You're going to have to continue to revisit your social contracts in light of more and more information as we go forward. Here's another example, and I changed this example in light of where we are right now with vaccinations, but let's suppose now we actually are forming bubbles with households that actually have high risk factors. So household one, both of them work in, they're essential workers, they work in a restaurant. Household two, one works as a bartender and often their patrons refuse to wear masks. So they have a risk factor coming into your social core. Another partner was working from home, but guess what? Now they're back at work again and they're working in cubicles. We have another household, both people are retired, both of them have received first shot of the Moderna vaccine. They're over 65. One person has hypertension. So what are the long and short-term mitigation strategies for this particular group if they want to socially interact? We need to be flexible in our plans. So for example, one person says, you know, we haven't gotten together since October because of high rates of infectivity in the state. Since you've received your vaccine shot, do you want to come over and have dinner at our house? And the elderly couple with one shot that is not yet fully vaccinated says, you know, we've only had our first shot yet, so can we eat outside? And the person who's inviting them says, absolutely, you know, until we're all vaccinated, we will all eat outside. We're going to eat at least 6 foot apart. And all of the people in household two, by the way, just so you know, as part of our social contract, all the household 2, which basically had a very high risk coming into the pod, they both are double masking. So they're very careful. And so the couple with the highest risk actually says, that's awesome. We're happy to go outside and have barbecue with you.
Bonnie,
Yes.
we're getting close to the end of our hour. We're within about 5 minutes, and we've got a lot of questions here. So I'd love if we could, I mean, say a few final words. I don't mean to interrupt, but it's really important that the folks get to be able to ask questions.
Absolutely, and that's fine because all of my next slides are all actually in my resources guide. And basically, I was just giving people resources for where they can find infectivity rates in the state and in the US. I like both the New York Times and Pima County websites. I like the New York Times because it actually tells you what types of activities they think that you're able to do depending on infectivity rates and how they actually calculate those. And then obviously the new CDC guidance, which I'm sure people will have questions about. We've already talked about the vaccinations. I wanted to just say one small bit about long-term care and post-acute care facilities that are actually working on guidance now so that we all can go visit our grandparents and our friends that are actually in these facilities. It's really important that we all know that many people need social interaction, and we're really looking forward to hearing more about this. And travel guidance is still very conservative, but we actually are hoping that that's going to open up very soon. So basically, you can see the summary. We're going to be changing all of our social dynamics over the next few months. We need to think about who's at risk, what our risk tolerance is, and start where people are. Let's start our conversations where people live. And then also, I'm just going to end on this slide so that everyone knows that there are a lot of people who have given me a lot of ideas, both about how to communicate some of these ideas, and also Deepta Bhattacharya, who actually, I'm an extremely conservative type of person when it comes to public health risk. And Deepta is always the one to explain to me that from an immunobiology perspective, I should be very excited about where we are and how safe we are all going to be. So I really like having a lot of perspectives and a lot of people helping me. So thank you all very much for working with me over the past year and a half.
Thank you so much, Bonnie. That was a fantastic presentation. We're going to start the question and answer part of I'll pause a few minutes. We've already got some really good questions, but if you have questions, go ahead and put them in, and we'll go from there. Again, thank you so much, Bonnie. That was a fantastic presentation, and thank everyone for their questions. So we've had a lot of really great questions. One that I see here is how does vaccination actually protect us from these incredibly scary variants that we're seeing coming from the UK and South Africa? What about vaccination is going to protect us from these potentially very dangerous variants?
Well, having more, so these variants can take hold when there's a high rate of infectivity. So as there's replicating of the virus, which occurs when we're spreading the virus between each other, these variants can take hold. So obviously vaccination is one of our primary ways that we combat that, because if we're not spreading it, then the variants don't have a foothold. And then the other is to just continue until more and more people are vaccinated, just continue to follow good public health practices. So that's how we're going to keep ourselves safe. What we don't want to do is have another huge outbreak the way we did over our holiday outbreak in the midst of these variants being around.
Sure, sure. There's some concern in the questions, and I understand this concern that is really balancing, if this is truly, these vaccinations truly protect us from serious disease. And they appear to do that very well. There's kind of this, and I'm seeing several questions around this kind of, if folks are willing to take that risk, at what point do we balance benefits and risk? If we're not, if we're this depressed and we're not exercising and we're not doing all of these other things, and we're protected against serious disease, what is the CDC? What is the CDC basing their recommendations on?
That's a great question. CDC is basically basing most of their recommendations on the current knowledge and state of science. Now, it is recognized by most public health people that we do have to balance quality of life. For a long time, we were just protecting ourselves. We see a light at the end of the tunnel now. So we have this ability now to make a more balanced evaluation in our emotional and mostly emotional and social well-being with our risks, which seem to be going down. And as people get vaccinated, they go down even further. So there is a balance, and it is a balancing act. And I think that what my talk was trying to do was have people think about this for themselves, that in a way they're in charge of this next step. They are purveyors of good guidance and good public health practices from local and federal public health officials. And they also have to take personal responsibility, both for their actions and for how they choose to make the balance between their own personal and psychological well-being. So we need to be able to start interacting. But my talk is more, how can we do this and think in the back of our minds, how can we do this while we lower risk, both for ourselves, but also other people? So how do we, it's going to be very complicated. This next 4 months is not going to be easy. It's going to be really hard. And it's going to be hard because there's a lot of good news. And it's like every day we're going to have like one more good set of news. But we are responsible for maintaining that balance between protecting ourselves and other people while starting to open up and socially engage again, which we all need to be able to do.
So I want to just kind of follow that up, because I got a couple of questions. One of okay, if I'm willing to take the risk, why can't, and I'm vaccinated twice, why can't I go to the gym? I had another question that said, if older people are vaccinated, the swimming pools typically open up here in Tucson in the 1st of April, and that's really a benefit to those people to be able to swim. So, again, I don't mean to push you, but these are the questions I think that are on people's minds, and certainly the questions that are coming up front. If we're willing to, if they're not, we're, and these people assure me they're not anti-mask people, and these are these are solid questions, and times are changing, and so people have these questions.
I agree. And so what we're going to see, I mean, we have to look to guidance for our, in Pima County, we have to look to guidance from the Pima County Health Department and from our Arizona State Department of Health Services that open things up. And then there have been gyms and facilities that have already been opening at a very slow rate and very safely. So some people might want to stay with those places that they know are safe. Other people, as we start opening things up, it's going to be a slow process, and it's going to positively affect everybody. It's not just the people who are vaccinated. It's going to be all of us. And so again, from my perspective, it's both our personal risks and also those around us. And our public health officials actually tell us what we are allowed to do. And then what we do is up to us.
Great question. There's been some confusion about the differences in vaccines, you know, the Pfizer, Moderna, J&J, and the percentages, and people saying, you know, that they're not going to take J&J or what. Can you kind of clear that up for us? Because I think that's a very important question.
Yes, I don't know that I can clear it up exactly for everyone, but I alluded to this early on. There is a real synergy between the personal protection that you're afforded by vaccines. And by the way, all the vaccines reduce the risk of severe illness. So that is full stop.
And that just stop there again, Bonnie, because I think that's the most important point. All of these vaccines prevent serious disease. So that was not what was tested. That's not the percentages that we're seeing. And that's such an important point that you just made, because that's where a lot of the confusion comes.
Yeah, I think that when drugs are evaluated, their endpoints are not always exactly the same thing, and their populations that they test drugs in, vaccines here, it's not really a drug, it's a vaccine, and the populations that they're tested in are not always exactly the same. However, for all COVID vaccines, it reduces the risk of severe illness, and it isn't that individual risk afforded by a vaccine is in a vacuum. So it's not like I don't have any more risk because I've been vaccinated alone. It's I have been vaccinated and the infectivity rates are down because more and more people are vaccinated. So we call this vaccine uptake. And the way that we all become protected is both all of us getting vaccines and then all of us being vaccinated, right? So they're synergistic. You can't just look at just one. They work together in tandem in a very, very high degree of accuracy.
Yeah, I thank you for that, because I think that's a really important message to get out. I had a really good question with vaccines, and I guess this is close to my heart because I work on therapeutics and molecular mechanisms that drive death. What will the role of therapeutics play? If everyone's vaccinated, what's the role of therapeutics?
That's a great question. And I think that it really depends on how things go and how quickly we can get. I have to get on my little tiny bit of my soapboxes because this talk has been very local. However, we actually have to think nationally, and even more importantly, we have to think globally. So your question about therapeutics and about how effective vaccines are going to be really depend on how well that we're able to vaccinate the entire world, because this pandemic, if it taught us nothing, is that none of us are so independent, except for these very small geographic areas that can be. Most of us are not afforded the luxury of living in a bubble, literally. And so if we can vaccinate enough of the globe and we can keep these variants down, then there will be people who might still get sick, and these therapeutics are going to be very necessary to keep these people from actually progressing to severe disease. So I think most of us will be protected, but there's still going to be high risk people. There are still going to be people who start with a mild case and end up in a severe case, and these therapeutics are going to mitigate that. So, I mean, one thing is to make sure that we're globally protected, and then these therapeutics will be used in a smaller and smaller subset of people, but then there are always going to be higher risk people for whom a poorer risk profile is going to be seen.
And that you kind of played up or set me up for the last question that I think, and it is, how or can we prepare for another outbreak, the next outbreak?
Well, I again, soapbox time. I think that we need to develop our public health infrastructure as we were taught. What the pandemic showed, it showed how lucky we are that we have great scientists that can move quickly and agilely and work and just so fast. I mean, this is just the magnitude of what we've seen in a year is just historic, okay? Unprecedented, I guess is the word. However, the gaps that we did see was how slow we were to be able to react in some respects, not because people didn't want to, but because they didn't have resources. So we have a real resource gap. And I think that if we're going to learn nothing from this, it's that we all have to understand that public health infrastructure is a vital part of infrastructure. It's as vital as roads and bridges and schools, which are also vital.
Yeah, I tell you, I've never been so proud to be a scientist as it's just it's for all of us. I mean, the scientific response to this has been incredible. Is not even strong enough. What has been done has been just by scientists here at the University of Arizona and all around the world. It's just been a magnificent thing to see. It's been devastating, but wow, without science, it would have been unthinkable.
Agreed. And we shared information quickly. It's been complicated for people. I mean, one of the things that I talked about was the fact that we're all purveyors of just an unprecedented amount of information. But the ability for us to translate this information quickly, as painful as it's been, is also historic and unprecedented. The ability for us to actually track and predict what the COVID-19, what the spread and what the profiles were going to be, and when our hospitals were going to get overloaded, and how many ICU beds we needed. This has all just been unprecedented for all of us.
Yeah. Well, I'm going to go back to Lisa as she started us off, and she's going to end us tonight. So back to you, Lisa.
Well, thank you, Ski, and Dr. LaFleur. Both of you, as Dr. Chilton just mentioned, are two of the outstanding scientists who have really led us through this very challenging, confusing time over the last year. And I want to thank you both personally as well as many of your colleagues who I know share in this work and this effort with you. I also want to thank all of you for joining us tonight. You had great questions, and we really appreciate that. We'd love for you to join us for the next installment of our Bio5 Precision Wellness in the Time of COVID Symposium, featuring our very own Dr. Skeet Chilton, who will do more than just ask the questions. He'll be speaking really from his specialized standpoint, and you're in for a treat there. So April 19th, please join us. And for more information on the Precision Wellness Initiative and our upcoming speakers, please visit the website address on the screen. And again, thank you for joining us, and we hope you have a great evening.
Thank you.
Thank you.
Bye.
Bye-bye.